Very nice. And thank you for teeing us up so well, because I'm going to now talk about diagnosis of heart disease in women. And certainly one of the challenges is that, as Noelle explained very well, the incidence and prevalence of heart disease is much lower, particularly in middle-aged women, but when it's there, it is more deadly. And so it's always harder to diagnose things that are less common, and especially when you don't want to miss them. So I'm going to talk in general about when it's helpful, when the woman or man comes into your office with symptoms and you're deciding, do you need another test or not? And so in general, for diagnostic testing, and particularly for chest pain, of course, history is very important. And in particular, going back to the old Diamond and Forrester article from 1979 in New England Journal, which is really an oldie but goodie because they looked at age, sex, and type of chest pain. And what was very striking in that article was if you were a middle-aged man and you had, the probabilities in the article, and you have classic angina, it's about 95% or more that you have coronary disease. And I'm now talking about angiographic coronary disease, so I am going to use that term. But if you are a woman and you have that same history, classic angina, the chances are actually about 65% that you will have obstructive coronary disease. And so that certainly the type of chest pain and age and sex makes a big difference. But for most women, particularly middle-aged women, you're still in that intermediate group. So certainly you want to establish pre-test probability before you think about, do I need a diagnostic test? Because I would say if you're really certain, probably don't need a diagnostic test. And if the chances are very low, you probably, again, don't need a diagnostic test. But for that very big group that's in the intermediate range, it is helpful to have a test. And then when you think about the test, you want to have a test that is going to lead to a change in management. Because obviously, particularly now, and I mean this in general, and also for coronary disease, we have a lot of tests. And so we can get a lot of information. But we don't want to order tests just to get information. We want tests that will actually give us information that leads to a change in management. And hopefully that will be, and as Noelle showed, a change in management that improves outcomes. And certainly the great thing about cardiology is we do have the 4 magic pills and we can improve outcomes. Or if the test is negative, that we can offer very confidently reassurance that our patient is normal. And of course, anytime you're considering a test, you want a low-risk test, not a test that is going to cause harm to your patient. So as I said, we have a lot of tests, and this was actually a slide from Mike Woke from a few years ago, but as you all know, there are lots of nice pictures we can get from imaging, and that is great, but I think the challenge is now to order the imaging test when it is appropriate, and as I said, when it will lead to a change in management and improvement in outcomes. And so a helpful test will lead to actions and better health. And again, something that's not possible without doing the test. Because if you could have gotten to that same outcomes or change in management reasonably without doing a test, one could question whether the test was really necessary. So as I said, we do have an abundance of riches with cardiovascular imaging. And we have echo, nuclear, either SPECT-MIBI, PET, PET-CT, cardiac CT, and cardiac MRI. All of them, except for echo and MRI, do have ionizing radiation. And I think that is an important distinction because of the cancer risks with ionizing radiation. And I am going to talk a little more about that. It is, I think, very important because our exposure to medical radiation has increased more than 6-fold between the 1980s to 2006, according to the National Commission on Radiation Protection. That's 6-fold increase in a little over 20 years. It's a huge amount of radiation. And the reason I think we really need to be cognizant of it is because it's estimated that the cancers that come from radiation take about 20 to 30 years. And of course, So that means now we are likely looking at a lot more cancers coming in 20 to 30 years due to medical imaging and radiation. So that's not to say we shouldn't be ordering tests with radiation, but it is to say we should be sure that we need those tests and that we can't substitute a test that doesn't have ionizing radiation. The last Institute of Medicine report on environmental causes of breast cancer, which was actually commissioned by the Susan J. Komen Race for the Cure Foundation, found that medical imaging was the leading environmental cause of breast cancer. Okay, so there is certainly a lot of information, and I'm just going to quickly go through, some of the things and the reasons people do order cardiac imaging tests. Cardiac CT, there's two different types. You can get a coronary artery calcium test, or you can do the cardiac CT angiography, which has contrast and more radiation dose than the coronary calcium test alone, and will detect plaque. You can look at characteristics of plaque. It is important to remember that any of the CT scans, you see more than just the heart, and you often see more than just that you wanted to see, and there can be incidental findings, and I'm going to talk a little bit more about those as well. They do make beautiful pictures. Here's a high-resolution coronary visualization, and as you can see, why it is so attractive to get imaging tests. We have great technology, and we can get beautiful images. This is just some of the ads, which I think I'll skip, for some of the full body imaging. This, as we discussed, CT can be used for screening tests. Screening means basically looking for disease in the healthy population, people without symptoms, and diagnosis, which we're really talking about tonight, is looking for disease in people with symptoms. However, as I said, you have to remember that there is a risk, for example, for a cardiac CTA, and I mention that because it is getting increasingly popular for what I think is low to intermediate risk chest pain in the emergency room to get a cardiac CTA. Just to look at the coronary arteries, because it is less invasive. It does require an IV with contrast, but it's not like doing a invasive coronary angiography. However, it's estimated that 1 in 270 women who have cardiac CTA at age 40 will develop cancer from that CT, which is not an insignificant number. And of course, that's the age group that, it's hardest to do the diagnosis. I will say, in general, women have a higher cancer risk from radiation at the same dose than men do. And of course, the younger you are, the more damage from ionizing radiation. So this was an actual case that it was actually taken from our journal, the Archives of Internal Medicine, from a few years ago from the Cleveland Clinic. And it's just to illustrate what I think is sometimes the attitude, well, getting an imaging test can't hurt. This was a 52-year-old woman who was slightly overweight, so she began a diet and exercise program, which I think we would all applaud. But she then started noticing that she had some sharp right-sided chest pain. It wasn't exertional. She did not have any associated symptoms. But, one of the downsides of the Heart Disease and Awareness Campaign is that it makes women worry that even if they have these more unusual symptoms, it could be a heart attack. And so she thought, well, I know women have atypical symptoms, could be a heart attack. So she went to see her doctor, and he was able to reproduce the tenderness on palpation by pressing on her right chest wall. However, and he, of course, did a careful physical. Her blood pressure was 142/85, so very slightly elevated. Her EKG was normal. He ran a lipid panel and C-reactive protein, which were all normal. So, what do you favor for the next steps? Does anyone want to? Reassurance. Does anyone want to do any testing? An echo. Well, okay. Stress echo. Well, he wanted to get a cardiac CT. So this was an actual case. said just to reassure her. But of course, we get the test hoping to reassure and then hoping that there'll be no calcium, everything will look great, but that doesn't always prove to be the case. And this woman did have calcium in the region of her left anterior descending. And so you know that if you have calcium in the region, you can't visualize the artery very well. And so now, because they weren't able to visualize the artery, she was referred for invasive coronary angiography. So now I have to say, you're taking this woman at 52 years old with atypical, very atypical chest pain. Her pretest probability is probably 10% at best for having coronary disease, but now, because we've gotten this test, she got referred for invasive coronary angiography. It did show normal coronaries, but unfortunately, she had an aortic dissection, which is a rare but known complication of an invasive coronary angiogram. So she had to go for emergency bypass. She had a prolonged bypass operation, and women do have more complications from bypass surgery than men do. And a few months after her bypass surgery, she came back in with chest pain, and her graft had occluded. So she got stented to that occluded graft. She did take dual antiplatelet therapy, but this woman obviously was born under a dark cloud, and she got a stent thrombosis. She ended up with a reduced ejection fraction and got cardiac transplant. And this was an actual case. So we published that as part of our Less is More series, and I will say, so we have the Less is More series in JAMA Internal Medicine, formerly Archives of Internal Medicine, and we try to highlight cases where there is no known benefit and there are definite harms. And this was the first case, actually, that we published in that series. We published this series because we just want people, I think there is somewhat of an attitude that it can't hurt to get a test, it will just, make everyone feel better, and that if test is not needed, or you definitely need to consider that there could be downsides to testing, particularly in this case to cardiac imaging with the radiation, and that there are other ways to reassure patients. So just to come back for the last few minutes on radiation risks of medical imaging, as I said, we are doing a lot more ionizing radiation tests and a lot more medical imaging. Another study from the National Cancer Institute that was published in the Archives of Internal Medicine in 2009 showed that just based on the CT scans that were done in 2007 alone, so just 1 year, obviously we're doing scans every year, but just taking the data from that 1 year, they estimated there will be 30,000 excess cancers and 15,000 excess deaths. And so, again, not to mean there are certainly times we have important information we need to get from CT scans, but I think we can all agree that there are also times that a CT scan is not needed or not the best test, and we're doing a lot more of them. There are, as I said, also the issue of incidental findings. So incidental findings are those little nodules or cysts in the lungs, for example, on a chest CT, and we see them and we're like, now what do we do? And often we'll say, well, come back for another test. Or sometimes we'll say, well, we need a biopsy, we're not really sure about that. Or at worst, or maybe at best, there's some anxiety because now you take this person who didn't know they had a lung nodule or whatever, and we can tell them they're low risk, but there is some anxiety left that you have this thing now in your lungs you didn't know about or wherever it might be. This was another study from Rebecca Smith-Bindman, who is a colleague at UCSF in radiology. Her team looked at 4 hospitals in the Bay Area and looked at the actual dose of radiation from the same test at those hospitals at different days and also on the same day. And I find this kind of astounding, but there was a 13-fold mean variation between the highest and the lowest dose for each CT type studied. So meaning, again, just depending on where you went, what the technician protocol they used that day, and other variables, you could get a 13-fold difference in radiation from the same test. And the unfortunate thing is our patients don't know whether they're at the high end or the low end when they're getting the test. And honestly, I don't think the technicians know either, or their physicians. There is a 6 to 22-fold difference across study types. And this was one example of, this was one of the scans they looked at, the multi-phase abdominal pelvis scan. This had a median of 31 millisieverts, which if you find chest x-ray equivalents more useful, that's 442 chest x-rays. But the range, depending on where you had the test and when you had it, was between 6.4 to 90 millisieverts for the same test. So the point is really that we could be doing a lot more to ensure low-dose testing, but right now the state of the art is that there is huge and unknown variability in radiation doses. I just heard today, actually, that the temporary SGR fix that sneaked through Congress yesterday has some additional criteria for radiology accreditation, and I hope that's true because there certainly is a lot more we could do to make sure that everyone is getting the lowest dose possible for scans they need. But currently, there is huge variation. And just for an example, a routine chest CT without contrast is 8.2 millisieverts, which is over 100 chest X-ray equivalents. This is some data also published in my favorite journal, Archives of Internal Medicine. And this was a case-controlled study that found that the sudden exposure of iodinated contrast media was associated with a 2 times risk of developing hyperthyroidism, which was statistically significant, and a small increased risk of hypothyroidism, which was not statistically significant. Okay, so just to finish up, this is actually probably recognized from the New York Times, but this was Nicholas Kristof, who I think is an incredible humanitarian and usually writes columns from his travels around the world about terrible things that are happening often to women and children. But this column was actually about himself because he had, I think, some abdominal pain and had gone for an abdominal CT scan, and he had an incidental finding in his kidney on that abdominal CT scan. It was a cyst, and he was told he should come in for a biopsy. And he ended up, I believe, getting a nephrectomy or a partial nephrectomy. And he wrote this column saying it was a scare, a scar, and a silver lining. And the silver lining, he said, was that he didn't have cancer. But, you know, someone likened it, and we didn't end up writing anything, of course, because it had already been done in the journal. But it's hard to call it a silver lining when you're feeling perfectly well and someone kind of takes you off the street, well-intentioned as it might be, and now you've had a big operation, he has a scar and he's lost his kidney. You know, one could say if you hadn't, and I don't know if he needed the CT or not, but certainly it doesn't seem like this is a great outcome for somebody who really was perfectly well. And Peter Libby, who is the chief of cardiology at the Brigham, wrote an article a little bit after that about the incidentaloma problem with medical scans, because certainly it's an increasingly common problem. Okay, this is just more data. It shows basically that we're doing a lot more myocardial perfusion imaging, and as we're doing it, you can see that the frequency of having an abnormal scan, and presumably not everyone's going to be abnormal, but we're doing them because we think somebody might have ischemia, but this is a pretty low percentage. We're down now to the 5–10% range, meaning that I think what this says to me clearly is that our threshold for doing myocardial perfusion imaging has gotten very, very low, and I think we really do have to question, is it gotten too low? 5 to 10% ischemia demonstrated means the rest of these people, could we have reassured them some other way? And this line here is, again, shows there's an increasing potential for false positive myocardial perfusion imaging as you've dropped your threshold, because, again, the more you do a test in a lower prevalence population, the more the chance that a positive will actually be a false positive and not a true positive. And this just shows that the breakdown of radiation exposure, the red is MPI, and so most of our radiation exposure is now coming from myocardial perfusion imaging. and that one test does seem often to lead to another. This was Andrew Einstein's study published in JAMA a few years ago, and they surveyed, I think, at their own institution for about 13 years at Columbia, and looked at patients who had undergone an index MPI and found that if you had one MPI, 39% of those patients were going to get another MPI in that time period. And the one MPI is equivalent to 39 mammograms. And some of these patients had up to 90, 100 millisieverts, which is a higher exposure than the people that were living near Hiroshima. So we are certainly giving a lot of radiation from medical imaging these days. So just to conclude, a reminder that we want to really think about all diagnostic tests and now imaging, particularly imaging with radiation. We want to choose tests for patients that we think are in intermediate range, and then we want to choose a test that will lead to a difference in management, improved outcomes, one that was not possible without the test information, and we should be sure that the benefits outweigh the risks of the test. So thank you very much.